Okay.
Should I start? Okay.
Thank you.
Also, firstly, thank you,
Well,
I think, everyone for being here. The aim of this talk is to, well, I think as the aim of the whole session is to talk about the personalization of therapy in hair loss. And we have been doing some progress in showing how we can incorporate genetics into the clinical practice to personalize therapy. So uh, before I always, before I start to talk about something, I always like to pose myself the questions as to whether does doing this new therapy or does doing this new technique improve the patient outcome? And in this case, the aim here is to provide information on pharmacogenetics. So pharmacogenetics being the use of genetics to predict response to certain drugs. And we know so far that pharmacogenetics has been very effective. So using genetics to predict drug response has been very effective in many important drugs, so drugs that started to be researched earlier in genetics, such as anticoagulants, psychoactive drugs such as antidepressants and so on. So both from a therapeutic point of view, but also from an economical point of view, genetics has proven to be good in terms of predicting and improving patients' outcome. So the final clinical patient outcome has improved. And then we go into hair loss. So why to apply this to hair loss? And advancing a bit on the presentation, what I aim to show you is that yes, we can use genetics, and it has shown to improve patient outcome to predict therapy for hair loss. Obviously, I'm talking about here pharmacological therapy. And when it comes to mind pharmacological therapy, I always start talking about minoxidil. Minoxidil is the best known drug. It is a first line drug. We always should start with minoxidil first. However, minoxidil doesn't generate a response to all patients. We have like 60% of patients responding to minoxidil and 40% of patients not responding. And this is pretty much an answer we get from all the clinical studies we have seen in all the drugs, combinations of drugs. It always stays at around 60–70% of effectivity for finasteride, minoxidil, dutasteride, everything. All the therapies, like the energy-based therapies, or everything, nothing surpasses too much. And obviously there comes the combinations and so on, and this is really why understanding the patient's biology becomes so important in order to provide a better therapy. But why is genetics important here, and why is my aim here is to explain genetics, is that when we see a pattern being kept like that across studies in minoxidil, for instance, and across different studies in other drugs, there seems to be, obviously, a genetic factor being, or an underlying genetic factor that leads to this difference in response. The drug is good, but not for everyone. So we started by looking at the literature and using bioinformatics to screen SNPs or screen genetic variants that could be relevant. And since we had tested previously 26,000 patients presenting or not under genetic alopecia, what happened is that we were able to see that some of the SNPs we had seen, they do correlate directly to androgenetic alopecia and also to the response of some drugs. After this retrospective study with 26,000 patients, we moved on to a prospective study with 250 patients in which we treated the patient effectively, or actually treated the patient, with either minoxidil or combinations with anti-androgens. I will spare you the details because I'll show the details later, because we have this to be shown here. So what happened is, remember that when we took into consideration only minoxidil, 60% of the patients, or about 60% of the patients, responded. However, before giving either minoxidil or combinations of minoxidil to another drugs to these patients, we tested these patients genetically, so we knew the patient's biology first. What happened is that we raised to 85 until 91% without statistical difference. between these types of therapy: minoxidil, minoxidil spironolactone, minoxidil dutasteride, or finasteride. So we've raised the efficacy from around 60% to around 90% without difference between the therapies. And the without difference between therapies means if we know the genetics of the patients beforehand, this means we can improve therapy regardless of what this patient's genotype means. Obviously, once you're able to do, and we are continuing the study to make a larger cohort of patients, we'll find more combinations and more genes. But so far, we have found some combinations, and mainly obviously affecting the sulfotransferase gene, the 5-alpha reductase enzyme 1 and 2, the receptor for prostaglandin D2. So these are genes that we had known before that to be correlated to the response to these drugs. So we tested them, and now we know that they do improve the outcome of these patients if we test them before. So just an image here, just obviously just representative, but we had many patients. And this is these are like some final details I'd like to show you. One of the possible implications everyone hears very often when it comes to hair loss therapy is the sulfotransferase. And we see that even when we take all the 26 SNPs we have seen, we see a very, even though the sulfotransferase gene doesn't correlate to hair loss per se, mind you, so it doesn't correlate to the mechanism of androgenetic alopecia, but it has such a strong correlation to minoxidil response that it does appear here in the mechanism of hair loss therapy, even though it doesn't have anything to do with the mechanism of androgenetic alopecia per se. So obviously we have genes like the aromatase enzyme, the 5-alpha reductase enzyme, the prostaglandin receptor gene. So those are expected, and also some vitamin relations, the AC enzyme, but the sulfotransferase enzyme, it has such a strong correlation to minoxidil response that it does correlate to many other kind of hubs of genes, and it does provide us a very good sense as to how the patients are going to respond to minoxidil and overall androgenetic alopecia therapy. And this leads us to kind of closing this a bit, what we are doing to the future. And to the future, what we're doing is that we have found very good mechanisms into understanding how patients will respond to hair loss therapy in androgenetic alopecia. But there are some skin conditions, some dermatological conditions that do present some intertwined correlations. So what we are doing now is that we are using this information we have from androgenetic alopecia to do correlations to the follicle silencing and how it does correlate to both, from one side, alopecia areata and skin diseases, skin inflammation in general. So what we hope to find in the future, and it seems for us that we'll be able to find, and this is a pretty neat image I want to show you with a bit more attention, is that when we look at the three main types of hair loss separately, when we can clinically correlate them, we do have good genetic determinants for alopecia areata, for alopecia, androgenetic alopecia, and for scarring alopecia. So we do have very good mechanisms we can understand. And this is looking at them separately. So we have main genes such as the AER gene, the HLAs related to androgenetic to alopecia areata. But what strikes us as very important and makes us look forward to seeing these results work is the fact that so far we treat androgenetic alopecia well. We have been able to improve this with genetics. But the fact that we are able to pinpoint some mechanisms of actions of drugs and their correlations to genetics and androgenetic alopecia also seems to be a possibility for us to, in the future, also use this understanding to improve how we treat alopecia areata, which is tricky, and mainly scar tissue or scarring alopecia, because we see overlapping mechanisms between, for instance, alopecia areata and scarring alopecia, and diseases that we already know more or less how to treat, such as psoriasis, atopic dermatitis, and seborrheic dermatitis. So we know some mechanisms from these drugs, and they already have, or from these diseases, and they already have some treatment and mechanisms we can explore. Thank you. So what we're looking to do in the future is to explore these mechanisms so that we can improve the therapy at least to scarring alopecia, which is very tricky to be treated, mechanism-wise very limited. So finding these mechanisms is one of our aims, like by using genetics, is to, in the future, find more mechanisms. Thank you very much. If you need any information, just please let me know. Thank you very much. Thank you very much. Again, my apologies. I'll need to leave, but thank you very much for accepting me here. See you in Paris, for sure. Thank you all.
Thank you very much. Okay. I would like to ask the floor not to take the picture or video because the conference organizing team, they already have the video recording. Okay, and next speaker.
Olfa.
Yes.
Orshani.
Yes, Dr. Olfa Orshani. Please welcome to the floor. The topic is predictive factors of patient satisfaction after hair transplantation, a real-life study from a high-volume center. Please, when you're ready. Thank you.
Good afternoon. I'm delighted to be here. My name is Olfa Orshani. I'm a hair transplant specialist in Racine Carré Clinic in France. Today, I want to share data from 217 patients that asks one honest question. What actually makes a patient satisfied after hair transplantation? And is it what we think it is? The answer changed how I practice, so I hope it will challenge you too. 5 parts today. Background, challenging an assumption we carry into every consultation. Methods, 217 patients. Rigorous stats, validated instruments. Results, one finding to remember. 3 clinical cases, each with a specific message. And 3 actionable take-homes. So let's go. Hair transplantation has never been technically better. Yet some results, some patients remain dissatisfied after excellent results. So that mismatch tells us that satisfaction is driven by more than the surgery. The literature is almost entirely technical, so we asked what actually makes a patient satisfied independently, what predicts the satisfaction most. 217 patients, single center, retrospective, minimum 6-month follow-up. We used the FACE-Q, the gold standard reported outcome instrument in aesthetic surgery, and study specific modules for expectation, hairline, and recovery, both univariate and multivariate regression. Limitations are honest, retrospective, single center, short follow-up. But these limitations just define the scope, they do not undermine the findings. Overall, patients are generally satisfied, 8.7 out of 10, and naturalness score even higher, 9.1. So patients don't just feel satisfied, they feel they look natural. 85% would repeat the procedure. 82% report improving social life. Mean confidence gain, 8.9 out of 10. These are quality of life outcomes. So the real question is not whether they are satisfied, but which factor drives that satisfaction most. Why does it work better for some patients than others? So the real question is what drives that satisfaction. Perceived naturalness comes first by a wide margin, 41%, more than twice density. And note, patients don't just feel judge density objectively. A natural hairline aesthetic harmony raises perceived density even when objective density is only moderate. Density itself, 20%. Then expectation fulfillment, 16%. This self-reported picture aligns with our multivariate analysis, which I will show you now. Perceived naturalness, odds ratio 3.4. So patients who felt their results looked natural were 3.4 times more likely to be highly satisfied. Expectation fulfillment, odds ratio 2.8. Hairline design, odds ratio 2.1. Total graft count, not significant. Operative time, not significant. No root stage, age, sex, not significant. The things we discuss most are not what drives the satisfaction. 61-year-old man, no root 5. He came in with old photos of himself from his 30s. He wanted that exact hairline back. We said no, we explained why, age-appropriate design, natural transition, graduated density. He pushed back. We spent 40 minutes co-designing a hairline he could trust. He left unconvinced. He came back. 3,200 grafts, natural line. At 12 months, satisfaction 9 out of 10. His words, "Thank God you didn't do what I asked." Sometimes the most powerful thing we do is redirect a patient toward what they will actually be happy with. That is expectation management at its finest. Case number 2. 31-year-old man, patchy beard. He had tried minoxidil for 2 years, no improvement. His goal, a natural result, even beard, so he could stop feeling self-conscious. Subtle result, satisfaction 10 out of 10. Only 950 grafts, one of the highest satisfaction score in our cohort. So volume is irrelevant. Alignment is everything. 42-year-old man, no root 4A, 4,000 grafts. Objectively, one of the best results of the year. Density excellent, coverage excellent, hairline natural. Satisfaction 6 out of 10. Why? Pre-op consultation was rushed. He expected hair like before. That expectation has never been challenged, was never scoped, never documented. So no technical quality could compensate. This case is in our cohort. It hurts to present it, but it's the most important case I can show you today. So 3 messages, each actionable for tomorrow. Design for naturalness. Our data is clear. OAR 3.4. Patients who perceive their results as natural are 3.4 times more likely to be highly satisfied. And there is a key insight. A natural appropriate result raises perceived density even when objective density is moderate. So stop chasing maximum grafts per square centimeter, chase natural transitions. Expectation management is part of the surgery. Technical alone is not enough. You can deliver an excellent, perfect technical result and still have a dissatisfied patient. So structure it, document it. A rushed pre-op consultation is a predictor of dissatisfaction, not a time saver. 3, stop measuring what doesn't matter, like graft count or no root stage. Yet these are the numbers we spend the most time discussing in our consultation. Our data says redirect the conversation, talk about design, talk about perception, talk about alignment. That is where satisfaction lives. So perception, not just precision. In 2 117 patients, 3 factors predicted satisfaction, and none of them were graft count, Norwood stage, or operative time. So the thing we measure most are not what patients value most. Let that change how you consult tomorrow. Thank you very much.
Okay, next speaker, Dr. Eva Stoilova. The topic is fractional 1570 nanometer laser therapy in telogen effluvium, a regenerative approach for follicular reactivation through energy-based modulation. Please welcome. When you're ready,
Thank you
please.
very much for invitation. It's great pleasure to me here and to present effectiveness of laser non-ablative therapy for hair loss, especially based of regenerative approach for follicle activation. I am Dr. Eva Stoilova, and dermatologist with 25 years experience in aesthetic market. Also, I am owner of 2 clinics in Bulgaria, and I provide education program through my Estavist Academy. Nowadays, I can analyze total increase of procedure during my daily practice. Patient asking regarding holistic approach based on regenerative treatments, and I can assess more patient asking treatments regarding hair loss and hair recovery. Based on clinical diagnosis, the most patient consider androgenetic alopecia, alopecia areata, and telogen effluvium. I can see regarding my clinical practice that cases with androgenetic alopecia increase a lot. Study shows us an increasement between 70 to 32% for the last decade. It happens the same with androgenetic alopecia and alopecia areata when we doubled our patient. But the most interesting diagnosis is telogen effluvium related with COVID-19 pandemic, where I can see different phases of clinical appearance, and finally I'm focused on these details. At first, I should mention physiological aspect of this problem. It is related with emotional distress, high depression, anxiety. It's not only correlated with female patient, but also male patient affected self-esteem and mental well-being. This disease has a multi-factor etiology. It's not only stress, it's related with acute and chronic systemic disease. Sometimes happens cytokine storm, dysregulation in hormone, side effects of medication, also changes in microvascularity after immunic reactivity. Telogen effluvium is non-scarring alopecia. Premature shifts follicles from anagen phase to telogen phase, and it reflects a disruption of follicle signing, macrovascular support, and also dermal homeostasis. It's covered hair area, but it happens as first of 5 post-COVID symptoms, and also we can see more and more female patient. Regarding demographic, we can see that this region of Asia can cause this problem and becomes stronger. Telogen effluvium appears more than 70% of the patient, reported onset after 60 to 70 days. Also, patient assess more than 90% depression, and 64 thought that avoid social engagement. Something interesting regarding Asian region, there is gene expression related with shaft diameter, and there is a thinness diameter, and also density is low. It is also important regarding therapy to have a sensitive endpoint to increase quality of diameter of the hair. There is conventional approach related with hair loss. We added supplementation, topical agents, using PRP to treat symptoms, but it is very important to underline biology, increasing of microcirculation, matrix remodeling, and also entering into anagen. Based on clinical data and regarding my clinical practice using laser therapy, I know that non-ablative laser can improve microcirculation, targeting microtrauma, and stimulate repairing and sealing cells. And in non-pharmacological in regenerative approach, improve environment and activate fibroblasts for activity. And the literature we present different studies regarding a wavelength of 50-40. In my presentation, I want to announce my clinical approach using 50-70, the new mechanism of action, non-ablative again fractionated approach, water absorbable laser with selective absorption, creating microtrauma controlled dermal healing in order to enhance microcirculation, remodeling a dermal matrix around the niche, and also provoke follicle resume the growth and results in restoration physiological hair cycle. Previously, regarding my PhD work, I have a comparison between using LED therapy, like photobiomodulation, non-ablative 50-70 dermostimulation, and combination between non-ablative 60-70 together with ablative in one session. And as monotherapy, I prove result according 120 patients. Based on the new approach, I use only wavelength 50-70 as mechanism of action for thermostimulation of fibroblast, increasing vascular growth factor for expression and improve microcirculation, creating collagen remodeling and perifollicular thread, and also induce anaphase through a beta-catecholine signaling. My patient is women in age between 25 to 60. All of them has COVID-19 history, predominantly a diffuse thickening. 68% no prior history of hair loss, and 83% reported moderate to severe shedding, more than 150 hairs daily, and 91% PUTES was positive. All participants were placed additional supplements and follow a standard hair care routine at home. Objectively, I do analysis before the treatment by trichoscopy, do hair pull test for all patients, and digital marketing, mapping the hair, and also patient-reported outcome through questionnaire. Laser parameter which are used with 50-70 nanometers was power 8, pulse duration 3 to 4 millimeter, density 3. I perform 4 sessions with 1 month apart, with cooling additionally, and follow-up was after a 4th session. I assess a stepwise regenerative response and observe satisfaction for my patient. Documentation before and after was based on higher matrix device, which gives us information for ratio between theogen and venous hair, also density and diameter of the hair. As endpoint, I have improvement in plus 6.1 point percentage in density gain. In frontal zone was higher, 8.3, because I adjust half of the energy only in frontal area. The diameter rose by 4.3 millimeter, and all of patient clinically was satisfied with improvement of shift, increasing anagen activity, reducing shadowing on hair pull test negativation, and also improvement overall scalp quality. I also has patients with seborrheic dermatitis, and they were very satisfied with improvement of this disease. Summarizing, there are no significant adverse event during my clinical study. There is transition erythema for 24 hours, no downtime, and high patient satisfaction. The role of the lasers can be mentioned for prevention of environment before any kind of hair treatment. It can be together with hair transplantation for prime the scalp and also to improve the results. In conclusion, non-ablative 50/70 fractional platelet is a part of regenerative approach for hair loss treatment to reduce the symptom, to improve patient satisfaction, and with well-tolerated, without side effects way, to achieve maximum aesthetic result. Thank you for your attention.
Very much for your excellent presentations. Next will be, we have small time for Q&A. Does anybody have any questions to the speakers? Dr. Ofa, congratulations for your excellent work. 4,000 transplantation, it was very nice. How come he give you 6 out of 10? Have you ever explored on something, apart from the result? Because a cosmetic surgery, in fact, it is we regard it as a prestigious product, like luxurious watch, like luxurious brand name. People buy it by emotion. So because of the excellent work, but he gave you just only 6 out of 10. Do you have an idea? Maybe he was upset or something?
Yeah, because of his expectations. Sometimes the expectation is not very well managed, so he expected another result. He expected another hair like his young age. So that's why he's not very satisfied because of the expectations.
Mm-hmm. Okay. Dr. Eva, your excellent presentations as well. Can you give some details about your laser 1570s? Because you said it will improve the scalp seborrheic dermatitis, right? In your presentation, but what mechanism can you?
We're talking about non-ablative fractionated laser.
we know that with this kind of approach, we create a microtrauma in the tissue, and also we increase environment around the glands, sebum glands, and control sebum production. Regarding this wavelength, we also have clinical studies prove effectiveness for acne scars, and inflammatory conditions related with skin disease. So in this case, I try to prove the effectiveness in the scalp area, which is very specific area, and very often patients suffered of seborrheic dermatitis and oil hair. That's why I used wavelength 5070 for deeper penetration comparing the other approaches, and which is very well tolerated procedure for my patient. Without an anesthesia, they assume total energy in stacking mode or emotion mode, because there is two options to do it. Unfortunately, a device which I'm using has very high cooling tip, so I use it before perform impulse for my patient, and it's create satisfied and well tolerated procedure. And actually, working with this device, we can assess effectiveness after 3 months, but regarding regenerative medicine, we can see improvement in the time. So it's very important to assess the maximum result after 3 to 6 months, because actually during this study, it's a part of my PhD, I was focused on 3 months to assess the result, like evaluation. But actually right now I saw that with the time and if I perform more procedure, for example, 5 procedure for my patient, this is my new protocol, then I achieve better result. And it is also very important for hair growth. It takes time. And of course, I want to present monotherapy in front of the audience, but in real life, in my clinic, I combine this technology with the other modalities, and then I achieve a better result.
Okay, thank you.
Maybe because you have, I know this device, you have dermoporation you can use to introduce on maybe cosmetic drug delivery through the same device, yes?
Talking with wavelength 5070, this is non-ablative, so I could not provide transdelivery.
Yes, but in this device,
fortunately, I show you that previously I combined very mild parameter with CO2 laser together with 5070 in ratio 1:1, because there is an option of grid. So in this case, I achieve better results because I combine transdelivery different modalities. And actually, I'm working with peptides to deliver maximum results. And also can be used different drugs, polynucleotides in the other modalities from regenerative medicine, and of course, exosomes to improve recovery time.
Because your device is very expensive.
I can provoke you that for me, expensive means that to turn back my investment should happen quickly, then it's not expensive. If I turn back my investment quickly, then this device is not expensive. It means that I'm an advanced doctor and I work with advanced technologies, because I really think that this technology, exactly which I perform my last study, it works in a unique way, and because this is specific scanner tip provide different regenerative approach in the tissue, comparing with the other technology 5040 And of course, I really think that photomodalities like LED therapy can have their places in our practices, but lasers gives us better opportunity to enhance treatments, especially prevention scarring, because I really think that if we combine this kind of technology before laser, non-ablative technology before surgery, we prevent scarring, which happens after each transplant surgery session. And also can maintain the results and improve the results in the future for our patient. Thank you.
Okay, please come forward.
This is for the hair surgeons in the room. A lot of Asians now are having their hair transplant at a young age, like 28 years old, both because of the trend that a lower hairline would mean youth and vitality, and for the feminization of the face, especially for those who are transitioning. So how do you design the hairline? Is it for the 28-year-old patient that is in front of you, or the 50-year-old version of himself that you might not see again?
Yeah.
So it depends of the no-root stage and the age. We try to be the most conservative with the hairline, because the hairline will stay all over the time, because the hair we take from the occipital area will not change. So we try to advise the patient to be the most conservative with the hairline. We start not to accept to have a hairline of this age, just for the long-term results.
Out of curiosity, what is the shortest number of centimeter?
We try to have for the homogeneous to have third for the, but we don't apply this every time. Sometimes we have more large side for the hairline.
For Asians, like the common is like 7 centimeters. How about you,
That's
doctor?
by theory, yes.
By
yes,
theory.
yes. Yeah, it's like we divide the face into 3 parts equally. So average distance from the midpoint here to the forehead is around 7 centimeters. However, there are many factors that we have to consider when you are doing the young patients. You have to look back to the family history too. Sometimes when they come to see you at age 20, everybody wants the teenage hairline. Yeah, like 6 centimeters, even 5 centimeters. But if you look at the family trees and there are class 6 and 7s, or in his family trees, don't do it. It's gonna be disaster for him, not for you, for him. Because next 10 years, you probably resign from this, but he still have to stay with his unusual hairline. And the second is the long-term maintenance. If the patient refuse to take any kind of maintenance, for example, medications or adjuvant therapy, it means that he probably lose more hair in the future so quick. So be cautious about a young age. But your mean age of the patient, 37, for me, it's 50, 55 for me. So it's different way to approach.
Thank you. Thank you very much.